may lie in a separate muscular fold, and this one of the nerves is here is the lateral femoral cutaneous nerve. This is the innervation, most commonly in the anterior lateral part of the thigh. The medial part is supplied a bit by the obturator. The knee joint may or may not be supplied by the obturator nerve. This is a cross section. This is a cross section of the L5 vertebral body. This is the psoas major muscle, very close to these great vessels, the aorta and the inferior vena cava. And this, what you can see, are the roots. So where you know that your needle tip is going to be in the psoas major muscle. Now, where in the psoas major muscle? If you get your needle from the posterior aspect, it has to lie in the posterior aspect of the psoas major. That means it has to lie in the posterior 1/3 of the psoas major muscle. Now, all these things can be seen by ultrasound except the lumbar plexus. So the peripheral nerve stimulation is a very good modality for the lumbar plexus block. The anatomical landmarks, you palpate the posterior superior iliac spine, draw a line upwards, you palpate the iliac crest, draw a line, and the point of intersection of these two lines is the point of insertion of the needle. The needle should be a 100 millimeter needle, a stimulating needle, and then you go through the skin, subcutaneous tissue, through the chordatus lumborum, hit the transverse process. Now, this is a very important aspect, that you hit the transverse process, because this is an osseous contact, and this is the only contact, this is the only bone contact that you get throughout the course of the needle. Once you contact the bone, that is the L4-5 transverse process, you go beyond that and dip your needle into the psoas major muscle. You start your nerve stimulation and then try to locate the origin of the femoral nerve. These are the two lines, posterior superior iliac spine and the iliac crest. This is the point of insertion of the needle. And when you dissect it, this should be the posterior superior iliac spine, and that should be the line from the iliac crest. And this should be the point of insertion of needle, so that the needle goes exactly, hits this transverse process, goes beyond that, and then you get the origin of the lumbar plexus. So again, the needle, this is the lateral view. And this is one of the imaging that I did. You can see this is at 0.3 milliamperes. I got the femoral nerve stimulation, the quadriceps contractions. So this is the needle. That is the origin of root above, and that is the origin of the root below. So we are nowhere near the root. It's quite away from the root. And if you go in the lateral, in the anteroposterior view, the needle is paravertebral. So it's nowhere near the epidural space. So whenever you inject your local anesthetic here, it has to go in the lumbar plexus. And the lumbar plexus, when you inject the contrast, you can see this is the vertebral body again. This was a patient who had ankylosing spondylosis, and this is the, see how many sheets are there. There are the various sheets, and that is the catheter in the epidural space. You can see the catheter coming over there in the epidural space. So this is a very important study. If you want, you can go ahead and follow this study. Farney, Dolet, and Girard in the Canadian Journal Anesthesia, and they have mentioned here, they have done a cadaveric study, and they have correlated needle insertions under CT scan under cadavers, and that is what they came to know, that the psoas, lumbar plexus or the femoral nerve is in the psoas major in the posterior 1/3. That is the obturator, which is quite medially, and that is the lateral femoral cutaneous nerve. So this is again a figure, that is the vertebral body, these are the discs, and this is the psoas major, which has been split into two, and that is the origin of the nerve which goes into the muscle, and that is the femoral cutaneous, and this is the femoral nerve which exits at the lower third of the psoas major, and your needle is somewhere around here. So if you put in your needle over there, it comes into this, and that is the spread of the local anesthetic into the psoas major. So exactly what you do is you inject into the psoas major muscle, and this has been sometimes wrongly labeled as a psoas compartment block. A psoas compartment is a huge, it's a psoas major, but a lumbar plexus is a well-defined lumbar plexus. So indications are the hip arthroplasties, fracture of the shaft femur, quadricephaly, open knee surgeries, and chronic pain. Now this is a video in a patient who had all these problems, but we are not interested in that. We are interested in the technique. See, this is the needle. Now this is diverted a bit more medially, as you can see. It is not vertical, because I could not get the possible contractions. This is the line through the iliac crest. This was the line through the posterior superior iliac spine. I exactly put in the needle over here. Now you can see the contractions of the quadriceps, and This was about the lumbosacral because it was a bit more middle. I could get both the lumbosacral plexus contractions. And that is the sacral plexus which will be dealt more with by Dr. Ashit in his next talk. And at around 0.6 milliamperes, if I get this, I'm going to inject the local anesthetic. So the major endpoint of a lumbar plexus block is contractions of the quadriceps. It is just as like you stimulate the femoral nerve, the patellar dance. If you get that, if you get a quadriceps contractions at 0.3 milliamperes, you inject around 25 ml of local anesthetic. Now this should be 1.5% xylocaine and 0.5% bupivacaine, which is injected, and also you can keep your catheter in case if you want to do so. Now I'm trying to assess the level of analgesia. In the upper he did not have, but in the lower he does have some amount of pain. So that it means it gives you unilateral analgesia. This is the area of the quadriceps, testing the femoral distribution, and in the sacral distribution, the sciatic, and this is where he can have some amount of pain. So that is how you assess for that. Now this is another way the patient is a sitting position. Now you saw the patient in the lying down position. This is the patient in the sitting position. That is the point of insertion of needle. This is the spinal column. So it is lateral to the spine. It's a paravertebral block. And I want to show you the end point. Now this is the end point. That is a patellar dance. Now she had a huge effusion here which had to be drained. She was in septicemia because of this. Now this had to be drained and she had all these problems. You can see that quadriceps contractions, and this can be quite painful in this group of patients because the joint is already effused and this can be painful. So you have to start with, what I do is in such kind of cases I start with 0.2 and 0.3 and 0.4 slowly, so that the patient doesn't have that amount of pain, because with 1 milliamperes or 2 milliamperes if you start, they will just throw on like having some convulsions. So again, a lot of studies done, but one by Farney, which I mentioned, and other by Capdevila. They have mentioned a good success rate with this particular block. Coming to continuous lumbar plexus, you can also put in a catheter tray, but the thing is that you have to infuse the volume first around 10 ml so that you dilate the space, and then there will be a very easy insertion of these catheters. And then you can put them on continuous infusions, and I always do a contrast study. Make it a point, if you're in orthopedic setup, have some contrast always by your hand, so that before the patient is sent out of the theater, just inject the contrast, see if the catheter is in place, and then you start your infusion pump. Because if your catheter is not in the place, there's no point in starting the infusion pump. So these are some of the studies which have been mentioned, which I have done, contrast studies which show nice delineation of the lumbar plexus. So another which you can refer is this, which has come in the journal, and they have everything about the lower limb blocks. Now, I told you about the CT imaging. I've done a lot of these contrast studies. You can see the contrast spreading over in the psoas major and the chordatus lumborum. You can see the transverse process, the needle hitting that, and just beyond that. This makes quite convincing that the lumbar plexus is in the posterior 1/3 in the psoas major itself. And again, the delineation of the whole of the psoas major. This is the sagittal and the coronal views, which again delineate the whole of the psoas major muscle. Again, you can see the catheter lying over in the posterior 1/3 over there, and that is the delineation. Again, it makes convincing that the lumbar plexus is in the posterior 1/3. That is just a 3-dimensional study. This was one of the first lumbar plexus block where I did not have a peripheral nerve stimulator, but with anatomical landmarks also you can hit the transverse process, go beyond that, and that is the injection of the contrast. This was done long back in '96. This was done for a short femur. Some of these cases, all in the distribution of the anterolateral thigh, that can be done. Except the problem is when they want to insert a nail through the greater trochanter, it becomes a bit difficult. Then you might have to infiltrate, or then you might have to give some amount of local anesthetic, or maybe a T12 L1 paravertebral block. Again, in these patients where it's impossible for a spinal and epidural, it's absolutely impossible to go in for a spinal epidural. You can give a lumbar plexus block and do some of these hemiarthroplasties, but believe me, it does not give you as good relaxation as a spinal gives or even an epidural gives. It might be a bit more shaky when it comes to relaxation, particularly if your surgeon is not accustomed to it. Now, one of my surgeons is quite accustomed to it and one is not. So it makes a difference in which kind of patients you give the block. Same type of surgeries in ankylosing spondylosis. And this is in one of the patients with scoliosis. This is also a bit difficult when you have it in scoliosis. So you need to have, because there's a difference in the psoas major muscle. You can see the bulky psoas major and you can see a small, thin psoas major muscle. So it becomes difficult in this particular group of patients when you give a lumbar plexus block. In cancer patients, that will be dealt with Madam Dr. Lakshmi was. One thing to avoid lumbar plexus is in the patients with retroperitoneal mass. This is because, see, this is the retroperitoneal mass, and when you give a lumbar plexus here, you can see the contrast which is being injected into the epidural space. We use a lot of alcohol in these kind of patients, and that's why it becomes very difficult to give this block. So it's very important to limit yourself the lumbar plexus and avoid patients with prior surgery on the retroperitoneum, patients on anticoagulants, patients who have undergone laparoscopic nephrectomy. A lot of things can be scarred in the retroperitoneal area, and in patients in whom posterior lumbotomy has been done for calculi. Renal injuries, psoas hematoma have been also been mentioned in many of these patients, because the lower pole of kidney is very close to the level of L3, and if your lumbar plexus is a bit high, then you might traumatize the renals. I got a minute. Ultrasound in lumbar plexus is a bit difficult because, as I suggested, you can see everything except the lumbar plexus in the ultrasound. So that is how I keep my probe. This is the skeleton. That is how I keep my probe. That is how needle is got into it. I hit the transverse process. So basically, you have to identify the transverse process, hit the transverse process, and then go beyond that, identify the psoas major muscle, and just in the posterior 1/3, if you inject the local anesthetic, you can get the lumbar plexus. Now let's see how we do it under ultrasound. That is the placement of the transducer. That is the iliac crest. This is the posterior superior iliac spine. The needle is brought in this fashion. I use a stimulating needle, and sometimes I don't. I'm just trying to compare these studies. That is how the probe is kept. We are trying to do it in plane. Then you see the transverse process. You see the vertebral body. This is the psoas major muscle. This is the nerve root, which pops in and pops out. When you shift the probe, it pops in and pops out. You get the needle from here, hit the transverse process, go beyond that, and inject into the psoas major muscle. That helps in creating a psoas compartment block under ultrasound. So that is the plane where you go in. So this is the stimulating needle, and that is the lumbar root. This is the psoas major muscle. That is the vertebral body. This is the transverse process. And again, this is the emerging root at the level of L3, and that is how you inject the local anesthetic into it. And once you inject, you can see the flooding of the psoas major. You can see now the root is being nicely delineated. While this is the spread of the local anesthetic, around 25 ml, or if you can come down to 20 ml. And when you take a contrast, you can see the contrast. You can see the nice spread again. So when you do it with a nerve stimulator, you can get this spread. And when you do it without a nerve stimulator, like just put in an epidural needle and then take a imaging of this particular compartment. And again, you can put in a catheter over there, and this is again in plane. So this is in plane actually. And then when you inject your contrast, you can see a nice spread. So sometimes there is no difference between when you use a stimulating needle and you don't use a stimulating needle in the psoas compartment. But it all depends upon how your experience. Like if you have been doing it for years together, then you will be doing it more faster and in a more correct fashion. So that is the obturator nerve, which is more medially, and this is the femoral nerve, which is more in the plane of the psoas major, and the lateral femoral cutaneous should be somewhere here. So all these things get blocked. Believe me that sometimes the needle can be directed a bit medially, because we are trying to put it in the posterior 1/3 under ultrasound. You can slightly insert your needle more medially, and in this case, if you inject the contrast, it is likely to go into the epidural space. You can see a small part going into the epidural space. So this is not in the epidural space. This is the lateral view, but a small part in the anteroposterior going in the epidural space. So there's a difference when you do with ultrasound and with the PNS, PNS and ultrasound and only ultrasound. So there is some amount of medial insertion of the needle as well as spread of the drug into the epidural space. Now, one of the contraindications, as I mentioned you, was there were some of the contraindications. Now, one of the patients, he came right walking inside, and I wanted to do a lumbar plexus for his girdle stone operation. So when I asked him to lie and I put an ultrasound, I was very fortunate that I did not put in the needle, because this was a psoas abscess. So I would have never have found him because he just came walking without any problem, and I just put ultrasound on that, so I could detect psoas sepsis. So these are the possible advantages of using an ultrasound over a PNS. But mind me that whenever you are using ultrasound, always use a peripheral nerve block to combine it with ultrasound. So this is how you can produce a efficient lumbar plexus.